house, which I wasn't expecting, so we appreciate you being here and for having us. My name is Samantha. I'm a pharmacist at the hospital here on the recovery care team. This is Athena. She's a pharmacy resident, so she's also a pharmacist. And then this is Michelle. She's the nurse from the team. So I'm going to let Athena get started, and we'll talk a little bit about some of the medications to manage opioid withdrawal, and then a little bit about the program itself. So here we go.
So this slide is just saying that we don't really have any conflicts of interest or anything like financial that we're disclosing. And then, so the objectives of this presentation is to identify signs and symptoms of opioid withdrawal, and then as well as identify treatment options for withdrawal management. And then afterwards, we'll just kind of go over what are the services that are provided at Red Lake with the recovery team. So, what is opioid withdrawal? First of all, I was just going to quickly go over what are opioids. And so we kind of have just a list of some of the opioids. A lot of times opioids are used for pain management. When it comes to opioid withdrawal, it can feel really uncomfortable or difficult or like symptoms, like flu-like symptoms. And we'll kind of go into a little bit later on what are maybe some more symptoms or things that people going through opioid withdrawal would be experiencing. With opioid withdrawal, it is rarely life-threatening. And with regard to it, with certain patient populations, though, we especially want to manage them with care, such as patients who are pregnant. So, why is symptom management important? It's to be able to really safely and successfully transition patients to medications for opioid use disorder. It's really like the first step before psychosocial treatments, and it kind of helps to reduce the discomfort. Did you have anything else you wanted to add just regarding symptom management and why it's important?
Okay, so Athena had mentioned that opioid withdrawal is not life-threatening, right? But it probably feels like it is in many ways. That differs from alcohol withdrawal, and that alcohol withdrawal can be life-threatening. So you can feel very miserable withdrawing from either. But with opioids, typically you're going to feel a lot of those flu-like symptoms pretty intensely for anywhere from a couple days to like a week, and then those symptoms change a little bit over time. So we'll talk a little bit more about what those look like. But essentially, withdrawal management is intended to make people feel less miserable in that first few days to week time period, and then to support them thereafter. Some of the long-term withdrawal symptoms we can manage with other meds, but a lot of times in the beginning we're going to focus on just a couple to help with both cravings and withdrawal symptoms.
So with that, with regarding to opioid withdrawal, depending on how long or short the different medications are, they kind of have different, basically last in your body for different amounts of time. So with short-acting opioids like heroin, the onset is it's shorter, it's faster with from 8 to 24 hours. And then the duration of symptoms can last for a longer time for 4 to 10 days. With regards to the longer acting opioids, the onset is a little bit more later on, from 12 hours to 48 hours after last use, and the duration is even longer, from 10 to 20 days. With regards to fentanyl, it's highly lipophilic, which is basically that it can get into your fat, and basically it kind of just gets sequestered into your fat, and so with that it can be present in your urine for 7 to 14 days after a patient is using opioids. So with regards to opioid withdrawal symptoms, they really develop over time, and they're kind of individual to each patient. So with some of the earlier symptoms of withdrawal can be things like runny nose, restlessness, excessive sweating, yawning, anxiety, and muscle aches. some of the symptoms that maybe would start to occur later on would be things like goosebumps, rapid heart rate, nausea, vomiting, diarrhea, abdominal cramping, and high blood pressure. Did you have anything you wanted to add regarding the symptoms of it?
No, this kind of like the, scientific list of all of them, it can be very different for each patient, and that timeline can be very different for each person depending on what they're using and for how long. But typically the questions that we're talking to people about in the very beginning is a lot about like stomach symptoms, body aches, if they're feeling restless, anxious, that kind of stuff.
With regards to like the potential risks of withdrawal, as I kind of spoke about earlier, especially if a patient is pregnant, it can be harmful to the child. So that's something we want to help manage, as well as it can increase the risk of suicide or overdose. Next, we're going to kind of go into treatment of opioid withdrawal. And so this is kind of the first essential step with regards to treating opioid use disorder. Patients with kind of severe chemical dependence can use higher doses of opioids, which to kind of like help with the withdrawal symptoms even. So with regards to kind of like treatment, of the withdrawal itself, that one rarely leads to the long-term recovery. That's more with just over time with the opioid use disorder treatment. So I'm kind of just going to go into some of the medications that can be used. And so the first one is clonidine. And with this, it is the primary agent when other agents like buprenorphine aren't used or unavailable. So it's not usually the first one that would be going to. It does help to really relieve those withdrawal symptoms. So some of the ones that we were talking about earlier, like sweating, diarrhea, intestinal cramping, nausea, anxiety, like those symptoms, it kind of helps relieve those symptoms. And something that this medication can do, just based off the way it works, is it can also cause some dizziness and also lowering your blood pressure. Is there anything you wanted to add on this medication?
So that one is usually used in the beginning of withdrawal management, so it could be used anywhere from like a couple weeks to maybe a month. Not the same for every patient, but typically shorter term, because if you're still having like some ongoing anxiety and irritation and things like that, we'll try to switch to other agents that don't have so much of an impact on your blood pressure. Unless you have high blood pressure and that works well, that could be considered. But this one is often started with another med, but it can be really helpful if you're feeling super anxious, that type of thing.
And then the next medication that I'll be talking about is buprenorphine. So this medication also helps to alleviate withdrawal symptoms, but it also can precipitate withdrawal symptoms as well if it's used too quickly after the last use of opioids. The other things that this medication can do, it can reduce cravings and prevent relapse. So this medication overall kind of just increases the safety, as well as in patients who do not use medications to help with opioid withdrawal, the death rates are higher in those patients as opposed to patients who do use buprenorphine.
Part of the reason for that is because, so buprenorphine is the medication that's in like brand names that you've heard, like Suboxone or Subutex. The Suboxone itself has 2 meds in it, and so when you take it, it helps with the cravings and the withdrawal because there is an opioid in there that will help kind of sit in the same spots that whatever opioids someone was using was in before, so it makes your body feel like you're getting what you need, basically. But it also has another med in there that protects you from the potential of overdose. So if you were to be on Suboxone and then using fentanyl or heroin or something like that, you're going to be at a lower risk of overdose just because the Suboxone's already on board, kind of protecting you in that way.
And then just kind of like what I was speaking about earlier with regards to precipitating withdrawal symptoms, the opioids can be found in a patient's body for days after their last use. So when you do use some of the other agents, it can cause you to feel like your symptoms are more severe and coming more quickly than if it was kind of if you weren't using it and it was just over time, basically, you were getting those symptoms. And then with regards to treatment, it shouldn't be delayed if a patient is experiencing any mild to moderate withdrawal symptoms.
So sometimes when we see patients that are like wanting help, but they're not in a lot of withdrawal yet, sometimes we have to wait because it's too soon and we don't want to make them sick. But sometimes we talk about what they call like micro-induction. So it's taking a really small dose of Suboxone like every hour if you're feeling symptoms. And it basically gives your body a little bit of time to acclimate to that being on board. So it's not throwing you into withdrawal, which is that precipitated withdrawal that she was talking about. It's kind of working up to a good level in your system slowly so that you're not feeling all those withdrawal symptoms. The odd thing is that if you've ever heard anybody say that they've gotten precipitated withdrawal, like they used fentanyl that morning and then they used Suboxone later in the afternoon and they felt worse, the treatment for that is actually more Suboxone, which sounds weird because it's what puts you into withdrawal, but it also is the thing that helps pull you out of those symptoms and treats those symptoms. So it seems very odd, and in most cases if people do that, they stop because they don't want to feel miserable, but it actually will get to a level where it helps those symptoms instead of making them worse.
And then the last medication that we're going to be talking about today is not one that is used to treat opioid withdrawal. It is only really used when a patient is at least like 7 to 10 days free from opioids. And then basically it works by treating your opioid cravings, anyone's opioid cravings, as well as kind of like not having any withdrawal symptoms with that.
So naltrexone is awesome because it works for opiate use disorder and alcohol use disorder because it helps treat the cravings for either one of those. But the 7 to 10 day window that you typically have to wait from the time you last use an opioid to the time you start this can feel like an eternity, right? If you're just waiting a full 7 days from last use. So a lot of times this option is tricky to get started just because people don't want to endure that withdrawal for that period of time. In some cases it works really well because if people have been off of opioids for a while but they're still having a lot of cravings, this can help. It also is available in a tablet form or an injectable. So if you're a person who doesn't like taking a tablet every day, usually we can start with an oral tablet just to make sure that you tolerate it okay, and if you do, the injectable is just done once a month. So that's kind of nice. You don't have to remember to take the meds on a daily basis.
Yeah, I think that's, oh, yeah.
Okay, switch. Oh, anybody have questions about the medicine at all yet?
How come methadone wasn't on there? I didn't see that.
So methadone is definitely a treatment option. It's not one that we offer here because to be a methadone treatment facility, you have to have special like certification to do it. I think the closest one is like Brainerd, St. Cloud area. So methadone is definitely an option. It's just not one that we offer here.
Do you think that they will ever offer it?
I'm not sure because it takes a lot to get certified to do that, and there's different rules for like Part 2 programs versus not. So I'm not saying never, but I don't think it's on like the immediate horizon. And that's just speaking like from the hospital. I'm not sure if there's other programs that are looking at offering it, but that's why we didn't talk a lot about it today.
Oh, okay.
Methadone is super helpful. It's different than Suboxone in that it's just the one medication and it goes to the same spots in your body that the opioids would. So it makes you feel very much like you're getting what you need. It's definitely one that you have to taper off of slowly should you ever decide you want to come off of it. And if like for folks that are on methadone and then say, okay, I want to transition to Suboxone, there's kind of a lengthy process that you go through to make sure the dose comes down far enough before you can start the Suboxone. So it's definitely helpful, definitely useful, but I think most of the folks that would be getting it here are going to be like going back and forth to one of those programs every day because they typically do daily dosing.
Which one is the blocker?
Naltrexone.
You
Yep.
use that with Suboxone?
Naltrexone? No, naltrexone is nice because they call it a blocker because it goes to all those places in the body where the opioids go, and so it sits in the same spot, and your body feels better because it's not craving something to be sitting in those spots. The Suboxone, though, if you were to use it at the same time, you're kind of going to block the effects of one, so it doesn't do a lot of good to use both together. Suboxone has that opioid that makes you feel better from a withdrawal perspective, where the naltrexone, the blocker one, doesn't. And so that one is nice because you can start it much sooner. And a lot of times when people are that uncomfortable, they don't think that they can wait, 7 to 10 days. And sometimes it's less than that. If they can come in and we don't see opioids in their system through like labs and everything, we can start it a little sooner. But if we do it too soon, you definitely make people feel worse than better.
I take Vivitrol
Mm-hmm.
for alcohol.
Okay.
What happens if I break an arm
So
or something painful?
yeah, absolutely. So because it goes to the same spots that pain meds go to, instead of using the typical opioids like they would, like if they were going to use Vicodin or codeine or something like that, they have to use different options to treat the pain. It can still be treated, but they'll have to use something else. The other thing is if you have like a procedure coming up, something they know is happening, they can hold the naltrexone or they can make plans for the Vivitrol to hold it for a certain period of time so that you can do your procedure, take the
They can
pain
go around
meds.
it?
Say that again?
They can go around it for a situation like that?
Essentially, yes. They just can't use, like, if they use option A for pain management, normally they have to use option B to make sure that's actually going to give you pain relief. Yep. And typically, if you're on Vivitrol or naltrexone like that, they'll give you, or there are, like, ID things available where you have a card in your wallet that says you're on Vivitrol, or I think they have necklaces and bracelets and things that we give patients just so that if there was, like, an emergency, first responders have a way of recognizing the fact that you would need option B instead of option A for pain management. Did that answer that well enough?
Yeah.
Okay. Any other questions about the meds?
How do you get on codeine?
Sorry, say that again?
Well, I got chronic pain and I just want to see something. I don't know what to do with myself, it's like real hard.
You said chronic pain, right?
Yeah.
So now, of course, in today's world, when you talk about chronic pain, there's a lot of different treatment options out there, right? So long ago, we used opioids for a lot of things. And in some ways, they are very helpful and they're very necessary. But in other terms or in other circumstances, it can be what causes someone to get dependent on opioids. So if you have chronic pain, usually the first step is to do an assessment where they can see, like, how well are you functioning? Can you do the things you normally do? Are you unable to do, certain parts of your regular life? And if you can't, it's called a functional status assessment that they'll do. And then they can talk to you about different options. Can you do, and what's available here, right? So there might be other options in other areas that include, like, acupuncture and all kinds of stuff. But typically, they'll do that assessment and then offer you things that are available, like, within this community or connecting communities if they could refer you out.
What was it? What kind of system?
It's called a functional status assessment. Yep. They have different pain assessments too, but typically they're going to do an interview to see, like, when does your pain happen? What makes it better? What makes it worse? What are you limited in? What are you not? That kind of thing. Mm-hmm. Any other questions? Okay. Sorry, go ahead.
How long could somebody be on Suboxone?
Honestly, yeah. So, have you met people that have been on nicotine replacement products for a long period of time? Like they stop smoking and they chew gum or they use lozenges or what have you for a long time? For some people, it's important to remember that Suboxone is not a drug, right? It's a medication. So you may need to be on it short term. You may need to be on it the rest of your life. It's totally dependent on how you're doing, like what your goals are with it. And in most cases, Suboxone, the goal of Suboxone is to get people back to their regular lives. It's supposed to be taken outpatient eventually, where you're not having to do daily dosing after a certain period of time. In the beginning, that makes sense because they need to follow you closely to make sure that everything is where it should be and you're getting the relief you need. But if you've been on it for a couple years, the goal is really to get you back to the things that you want to do, whether that's work or engaging with family or what have you. So some people, yes, could be on it lifelong. Years ago, I know there was a lot of discussion about, okay, well, they're on this dose, we need to try and taper them down, right? And that's probably not gone. That thought is likely still out there in many areas, but it depends on whether you're looking at it from like a harm reduction perspective or you're looking at it from a more punitive perspective. Our goal is never to look at it from a punitive perspective, so we just want to make sure people get what they need to re-engage in whatever it is they want to do. So in most cases, if people are following up with their doctor and able to do all those pieces, there's no reason that you can't be on it long term. These are good questions. Any more?
Suboxone's not a drug?
Well, I say that because I don't want it to sound like a drug in the negative sense of like, don't do drugs. I was raised in the DARE age.
Is it under the controlled substance?
Suboxone? Yeah, it is a controlled substance. So, but we call it typically a substance or a medication because it's not an illicit drug. And honestly, I might use the word drug throughout this presentation, but most times we try not to, just to try to improve some of the stigma surrounding it. Because some folks will come in and say, I don't want to do Suboxone. I'm not one of those people. I don't need it. And it's really intended to be a medication to support you, not you're trading one thing for another, if that makes sense.
Can it be abused?
Suboxone is nice in that it's much tougher to abuse it than it would be something like methadone or Subutex because it's got that other med in there that helps kind of protect you from abuse potential. I'm not saying it's impossible, but if you ask the drug company, they'll say it can't be abused because of that second medication that's in there. And in most cases, it's much safer, and the overdose potential with it is much, much safer than with something like methadone or Subutex.
What is macrodosing?
Macrodosing?
Yeah, I didn't really know.
Sure. So so anyone know what the max dose of Suboxone is? Like what they say the max dose of Suboxone is?
24?
Yes, everyone's passing. Bravo. So that's what the drug company says that's the max dose, right? But when they did all of the testing and FDA trials and all that kind of stuff, people weren't using fentanyl then, right? They were in most cases using like prescription opioids, or they were using heroin. And so the studies that they have to support that dose, they're learning maybe need to be updated with additional studies because there's a lot of synthetic stuff like fentanyl that's out there now, and it's a lot more potent than those other meds were. So microdosing, I mentioned earlier, is when you do like little bits of Suboxone at a time to kind of build up a tolerance in your system. Macrodosing is this person feels tough, I'm going to give them a high dose right away, right now, to get them feeling better. Whereas, like, even through our program, when we see you, we'll give you a dose and then often adjust it upward instead of throwing you on the max dose and then seeing if that works or not. There are places that do higher than 24 milligram doses depending on what program, what their policies entail, that kind of thing. And there are like clinical reports and things like that out there that have shown benefit with doses over 24, but because they don't have a lot of data yet, and because all of the initial like research was done up to 24, that's what the drug reference will still say. But macrodosing is the thing, and some facilities use it more than others. Mm-hmm. All right, so like I had mentioned, our program, we call it the bridging program, or the recovery care team is another thing that we call ourselves, I guess. And essentially, the goal is to put the patient first. And so I'll give you like some brief history here, but around like the beginning of 2020, end of 2019, there was a work group that included a lot of programs from the community, including the hospital, called Helping Hands. And they determined that there was basically a big treatment gap for pregnant people that needed medication for opioid use disorder that weren't able to access it in the area. So the goal was to function through this grant and work with like Chemical Health and the hospital to try and get pregnant people in and get them started on medications that would help with opioid use disorder as a whole. And then really to continue it after they had baby and support them throughout that time. So when they initially looked at it, the goal was really just to provide some access point because there really weren't a lot of, if any, providers in the area that were doing it. There have always been programs further outside of the community that you could go to, but transportation is an issue, and it's challenging, I guess, especially considering the weather conditions we sometimes have. So the goal was really to do this pilot project with these pregnant people and see how it went, and then COVID started, and it kind of changed the ballgame a little bit. There was just a lot more need It was a lot more challenging for folks to get to their previous treatment programs or even to get started in a program. And so there was a lot of collaboration between chemical health and the hospital and additional community programs to try and find a way to expand access. So that said, initially there was one provider that was the champion at the hospital, and she was super supportive, and her and then another nurse and another pharmacist, because we didn't start it, we just are fortunate enough to work in it now. They kind of pushed the program forward, and really the goal was to include the pharmacist, the nurse, mental health specialists, and then ER and primary care providers. So I'll talk more about that, but the goal was really to provide an access point anywhere within the hospital. That kind of came over time, but the goals of the program itself are here. So we are not a long-term program. That's why we call ourselves a bridging program, because the goal is really to get folks started on medication when they're feeling miserable or when they're ready for treatment. And that medication can be lots of different options with the exception of methadone. And we don't tell people what they're going to use or what we suggest that they use. We give them their options and try and help them figure out what they want to do. So it's really transitionary care. We get them started, we get people more comfortable, and then we try to help with care coordination from day one to see where we can get them for long-term treatment. Like I mentioned, multiple points of entry. So historically, there was a lot of rules around Suboxone where only certain providers could prescribe it, and they could only prescribe so many days at a time, and they could only have so many patients that they saw in total. And so over the years, as we heard more and more about opioid use across the country, they changed those rules. And so they made it easier for providers to write for that medication. So now all those waiver things that we used to hear about are gone. So any provider that is, trained and comfortable to do it can do it, which is cool, because before, when we had patients that would come in like to the ER uncomfortable because they were withdrawing, sometimes the providers that were there didn't have that waiver to provide the medication, weren't really familiar with it, and so patients wouldn't get access to that medication at that time. So that was kind of a treatment gap that was recognized when we were starting this whole deal.
Do you have a question?
Yeah, so does that not make it a Schedule 1 then,
It-
if all those rules are taken away from there? Or?
Yeah, it's still a controlled substance, but before they had that, they called it a data waiver, and it would require physicians to do a very lengthy training, and they could only prescribe so much to so many people. They removed that waiver in order to allow more providers to write for the medication. So it's still a controlled substance. It's still, if you were to pick it up from pharmacy, you still have to have an ID to pick it up, all those kinds of things. So none of it changed from a DEA perspective, but they loosened the prescribing regulations to try and allow more providers to provide it to their patients. Any other questions? Sorry. Okay, so the other goal is really to connect people with additional services, so wraparound services. We are really forthcoming during the first visit saying that we're not a long-term program because we don't offer things like groups and stuff like that, so we really want to get people connected to chemical health or whatever program they're hoping to stay with long-term, just because we want them to have access to those things. And then we also talk about, we talk about withdrawal management, which we'll do a little bit more, but the overall goal is to just kind of meet people where they're at. That may look different on a day-to-day basis, but if we're seeing them in the ER, we're seeing them in outpatient, wherever, the goal is just to try to help fill whatever gaps or whatever needs there are in that moment. All right, so my role as a pharmacist, we're really fortunate to be able to do this at the hospital. So we have something called a collaborative practice agreement, which is a fancy way to say that we get to work with the providers and see patients. So there's certain things that are outlined in there that we can do, but basically, first visit, usually you're going to meet with the pharmacist and Michelle, the nurse here, and we'll talk about what's going on, where are you at. We can do the physical assessment, so we're checking your blood pressure, and if you need a foot exam, we can do that, all those pieces. We're also talking about your substance use history to see when did it start, what does it look like now, what does your treatment history look like, have you ever used any treatment meds before. And the first visit is the longest for sure, and we'll talk a little bit more about that in a minute, but sometimes that first visit, people are so uncomfortable that we're not getting to all that discussion. We're going to work on withdrawal management first and foremost, because if folks come in and they're miserable and they're throwing up in the office, we're not going to get through all of those pieces on day 1, but we're going to try to get back to them like on day 2 or 3 or whenever they're feeling a little bit better. We do a lot of education, so talking about the medications, talking about how we can support them in a lot of ways. And honestly, sometimes when we see patients, they might come to us because someone told them they should come in and they didn't know a lot about the program, and so when they get to us, they might not be ready for treatment. And if they're not, that's okay. So part of our role in that and in care coordination is providing whatever services we can. So connecting them to syringe service programs or giving them a kind kit through the pharmacy, those types of things. So just recognizing that not everybody is even ready when they come see us, and that's okay. We also have a warm line. So in the event that we need additional assistance, we do have folks that we can reach out to nationally that give us additional recommendations beyond the providers that we have in-house too. We don't have to use it often, but it's available. So we have a lot of resources, and we're really lucky to work with all of them and to work with all the providers at the hospital. So that's kind of our role, and we'll talk a little bit more about that as we go. But I'm going to let Michelle talk about nursing here.
So the nurses role in our clinic is I do a lot of follow-up visits. I meet with patients and we discuss how they're doing, what their symptoms are, if they need anything medication-wise, or we just kind of talk about what's going on with them. I'll do an assessment, and that's where we talk about whether the dose is doing okay, if it lasts the full 24 hours or not, and then we'll kind of talk about adjusting the dose too. We do a lot of education, especially like Sam said, that first appointment, because a lot of people don't even know what precipitated withdrawal is. So it's really important that we educate the people that it can happen and it can make you feel really sick. Then part of it is we do referrals to different treatment centers. And so I talk a lot with different treatment facilities about patients' care, depending on where they want to go and what their goals may be. And then we do the documentation as well. So.
Are you